So welcome to another video. I'm the NICUDoc. And this month of September, we're doing the NICU Awareness Month series. Last week, we talked a little bit about if you're a new parent coming into the NICU, what you should expect, what you can or can't do, who are the people around you. If you haven't seen that video, please go ahead and click right up here. Nelly Figueroa on YouTube asked a question if I could explain a little bit about SIMV or modes of ventilation. So I'm going to go ahead and break it down. She is a nurse, and so I'm going to be really breaking this down specifically for nurses, medical students, residents, to kind of get a better understanding of the type of ventilations that we have. And this is going to be fairly basic. I'm not going to go into too much detail. So we're going to talk about mechanical ventilation first. Then we're going to be talking about non-invasive ventilation. And then at the end, please stick around because I am going to be talking about the gases. So when we talk about the ABG and your CBG, how do you actually read? How do you go through that? Which one is the pH? Which one is the PaO2 and what they actually mean? So stick around to the end so you can actually get the whole kind of sense of gases and how we kind of look at those as clinicians. But before that, let's go ahead and talk specifically about mechanical ventilation and non-invasive ventilation CPAP. All right, let's get to today's video. Giving the trainees all those NICU secrets, teaching the families, bringing you physiology and the latest evidence in management of NICU babies. Just having fun with it. Okay, so we talked about the different modes of doing this through volume, but what that actually means is you can actually go ahead and give that breath, doing it as a pressure limited or a volume guaranteed delivery. What that is basically how do you stop, how do you limit that cycle? We talked, remember, getting to the end of a cycle, how do you stop it? In pressure limited, you basically set a limit of pressure for you to go up to, and then the machine's gotta stop at that point. So again, let's just say we decide to go and use pressures of 18. That means that the machine will deliver 18 every single time. It's not gonna go to 20, it's not gonna go to 22. Now you may actually read on the ventilator that it may be a 19 or a 20. That's because the ventilator is actually reading what the pressure is close to the baby's lungs as you are delivering your pressure and as the baby may be breathing out, or there may be a little water in the tube and stuff like that. So the machine may be measuring a different number that should be close to what you have set though. When you talk about volume guarantee, you basically guarantee a certain volume. So that means if you set a volume of 5 milliliters per kilo and you've got a 3 kilo baby, then that machine is always going to want to go as close to or to 15 milliliters each time. What is the difference in each of these? When you're doing pressure limited and you're going to 18, the volume that the alveolus actually sees, that your air sac sees, will change. One breath, it may see a bigger volume, and the next breath, it sees a smaller volume, depending on what's happening with the lung, the dynamics. Is the baby breathing out in? Is there a lot of fluid? Did the baby move? There's so many things that causes these little changes in volume, but it's always going to try and obtain the pressure it wants. Now, the opposite effect happens when you're doing volume guaranteed. It's always trying to get that volume, and it will go ahead and do whatever it needs to as far as the pressure is concerned to get to that volume. It needs to get to 15, and sometimes it will use higher pressures to get there. Sometimes it uses very low pressures to get there. And so that sort of tells you the difference. And to be honest with you, there are some data showing that possibly doing volume guarantee may be more beneficial to minimizing, damage to the lung on a long-term standpoint, meaning chronic lung disease or bronchopulmonary dysplasia, and also decreasing the risk of pneumothoraces where the lung collapses. However, these have been looked at, and in studies, they haven't really gotten a good research quality, meaning they're not blinded studies, they're unblinded studies. So the quality of the research that's been done on these type of studies is kind of low, but what has been done has shown that there may be some benefit of volume guarantee versus pressure limited to decrease the risk to the baby and the baby's lungs. Okay, there are completely different other tricks and modes, and there's so many other little things, and you guys can read up. There are other videos too on YouTube that are great that go through this different modes in details. I'm just gonna touch on those two just to keep it basic, keep it simple. Okay, I'll mention briefly high frequency ventilation. That in itself is a whole talk, and if you guys are interested, let me know in the comment section below, and I'll go ahead and make a whole video on high frequency ventilation. We have the oscillator, we have the jet. It's used for different reasons. They do different things, but for the most part, high frequency ventilation is basically a mode where you are delivering very, very, very small tidal volumes. I kind of mentioned kind of little packaged volumes into the lungs, but you're doing it at super high rates. So what it is we use hertz, and hertz are 60 breaths per minute. 60 breaths, meaning if you're on hertz of 10, then you're actually delivering 600 breaths per minute. Most of these premature babies, you can have them on hertz or frequency of 15. You're getting 900 breaths a minute. The high frequency ventilator is excellent at basically being able to do oxygenation and ventilation completely separate from each other. Meaning, if you have an oxygen problem, you can do so many changes on the high frequency ventilator, and it doesn't affect your CO2 at all. If you're having ventilation problems, you can make changes to the ventilator only for CO2 issues, and it won't change how much oxygen you're delivering. Very different from mechanical ventilation. When you're on regular mechanical ventilation, anything you do actually affects both. If you go up on your PEEP, it's going to affect your oxygenation and your ability to blow off CO2. Well, again, high frequency ventilation is really, really close at being able to completely separate, and that way we can play with that to be able to decide which one do we want to do. Sometimes you have to work on both, and then there are things that you can do to really work on both. Another thing that high frequency ventilation is really good at is getting rid of CO2. It's a great machine for when your CO2 is super high, you can't get that down. You can do all these tricks to really blow off CO2, and it's pretty amazing. It's also really good at being able to pump oxygen in and trying to minimize how much damage you do when you're actually putting pressure in. You're gonna damage the lungs anytime you do any ventilation of any type, because you're putting pressure each time. Each rate is pumping air into the lungs, causing damage. But unfortunately, it's one of those necessary evils. Without that, babies won't survive, so you have to do this. But the most important thing is choosing the right mode, the right ventilator, and whatever you need to really try and minimize the damage that you do and maximize how much a baby can live and get stronger and be ready to go ahead and take the breathing tube out. Best thing you can do is take that breathing tube out. If you are ready to do it, go ahead and do it. And I know there's always some reluctancy to do so, but that is the one thing that can really decrease the risk of bronchopulmonary dysplasia or chronic lung disease. Let's go ahead and move on now to talk about non-invasive ventilation, or NIPPV, which is non-invasive positive pressure ventilation, or NIV, non-invasive ventilation. So what is non-invasive ventilation? The term basically tells you it's where you don't have a breathing tube. You're basically just doing similar modes, except that no longer with a breathing tube or an endotracheal tube. The settings are pretty much the same. It's the same idea. You've got synchronization that happens with the rate that you said, with a PIP and a PEEP. And so it's very similar in that sense. What's a little bit different is that obviously the pressure is not being delivered directly into the trachea, into your windpipe. And so you tend to lose a lot of pressure. There's different ways of doing this. You can have a mask, you can have prongs that go in the nose. And so when this happens, you obviously will lose some pressure through the nares, through the actual, if you got prongs or masks, some of that can, even you might not have a great seal, some of that can actually come out through the mask, through the prongs, it comes out through the nose. If the baby's mouth is open, obviously sometimes that comes out. There are some places that use, sort of a chin strap to keep the mouth closed to try and maximize as much of the air going into the lungs and not, coming out through the mouth. There are other things that you can do to try and minimize, again, this changes in airflow. But what's really important always is, yes, you want a tight seal, but you also have to keep in mind that tight seal also means tight pressure on the skin. So this is one thing we always have to be really worried with in general with any baby. But when you're doing non-invasive ventilation, nurses have to be really on top of checking the damage that can happen to the skin. That pressure can cause pressure ulcers in the areas of the skin, very typical around these areas. So there must be a constant observation, and if they see that, obviously you guys take that to your manager, follow your policies, whatever your recommendations for your clinic, your hospital, and just follow those policies. But it's really important to keep in mind the skin damage that can happen from that. Okay, weaning from NIPPV or NIV, similar to an intubated patient, a patient with a breathing tube, you work down on your rate, you work down on your pressures to get to a comfortable spot. And again, I'm not going to speak specifically about what those numbers are, because every patient is managed differently. Every clinic, hospital manages that differently. So obviously speak to your clinicians and they can give you some of those numbers that you guys use for those that are new nurses or practitioners. But when you wean to a point where you feel very comfortable, where you can go ahead and take the rate off, some people do it at a rate of 20 or a rate of 15, some people go as low as a rate of 10. You go ahead and take the rate off, that now becomes CPAP, continuous positive airway pressure. We talked a little bit about this when we talk about PEEP. That's essentially what it is. It is a continuous positive pressure that holds the lung open and prevents the lung from completely collapsing. So this time though, we are not doing a pressure to open up the lung. That is the baby. The baby's working on that. That's why you have to make sure that the baby's safe and strong enough to be able to take that nice deep breath. But once it takes that deep breath, you're basically sustaining that lung open as it's relaxing so it doesn't completely collapse. And that is that CPAP pressure. Most places will do anywhere from 4 to, depending on if the baby has chronic lung disease, you can sometimes go 12, 14, 15 in certain hospital and certain clinics. They use that for the really sick and stiff lungs. But again, go with your hospital policy, talk to your clinicians about the specific numbers. Okay, so again, CPAP keeps the lungs nice and open. If you are getting into trouble, you may need to add a rate on that, and then you go back to NIV or NIPPV. Okay, so we've talked about mechanical ventilation, non-invasive ventilation, and CPAP. Now, you guys have held on this long. I really appreciate it. So let's actually run really quickly through reading an ABG. When you look at the results of an ABG or a CBG or any type of gas, there's a pattern you want to look through the results at. The first thing you want to look at is your pH, and that's your acidity level. We know that in general, to keep homeostasis, meaning keeping the baby's equilibrium and balance, you want to keep usually the pH between 7.35 to 7.45 in regular full-term babies. This is very different from preemie babies. Preemie babies, we do something called permissive hypercapnia. What that means is that you actually allow a little bit more acid level. You can actually drop that pH. Your pH is lower, that means you've got a little bit more acid. If your pH is higher, you're more alkali. So we allow the pH to drop a little bit and the CO2 to rise in premature babies just to minimize the damage. As I mentioned before, every time you're using that ventilator, you're causing damage. So Basically, permissive hypocapnia allows you to back off a little bit on how much pressure you put into the lungs. And it has been shown that allowing the CO2 to go up a little bit and allowing the pH and the acidity to drop a little bit is okay. And it actually protects the lung so they do well in the long term. What that actual pH is, it really depends on the size and gestational age of the baby, your institution, how comfortable they are with those numbers. So again, look to your clinicians for the specifics on that. The next number that comes up is your CO2. Your CO2 is really important to determine if you have too much CO2, you may be actually acidic, you may be holding on to CO2 for whatever reason. In general, again, full-term babies would be around 40 for CO2. If your CO2 goes above 65 in most places, even for premature infants, that's not a good thing. And so again, you have to intervene. When the CO2 goes up quickly, it tends to be because there's something going on in the lungs. You have to keep in mind that CO2, the first CO2 number you're looking at, there is still an interplay between CO2 and we'll talk about the bicarbonate with the kidney. So it's not just a lung issue, it is also a lung-kidney interplay. We'll talk about that when we actually talk about bicarb real quick. The next number you look at is your oxygen or your PaO2. What's really important about understanding PaO2s is that it is the amount of dissolved oxygen. It does not tell you the actual oxygen level in your blood. Has to do with saturation in that, yes, there is oxygen that is attached to hemoglobin in your red blood cell, and so yes, it is technically in your blood, but PaO2 is dissolved oxygen. And so there's a lot of dynamics that happen between the lungs and the heart to give you that dissolved oxygen. So not necessarily if your PaO2 is low, does it mean that you have really bad lung disease. There may be a cardiac issue there too, and sometimes it may even be normal if there is a type of shunt. Again, that's a topic in itself, and we can definitely delve into that if that's something you guys want me to do. A normal PaO2 for a newborn in utero, that means before coming out, usually around 20, 25, something like that. When a baby comes out, usually around 40, 45, 50, okay? So this actually, it doubles the amount of dissolved oxygen you get, and again, because now you're taking nice deep breaths, it sort of doubles. The next number that we typically see is your bicarbonate. And your bicarbonate, as I mentioned already, has to do really with your kidney and the interplay of your kidney and your CO2. Why? Well, bicarbonate acts as a buffer. And what is a buffer? Buffer basically is the ability to counteract acidity. How does it do that? A buffer, in this case, bicarbonate, which has got a negative ion, will attach to a hydrogen positive ion, and hydrogen ion is your acid, if you will. And when your negative ion and your positive ion come together, just like magnets, they come together and it forms an actual component which is no longer acid or base. It's basically neutral, and then it can go around and be in the bloodstream. So the acid can come from the CO2 part of the lung, or it can be picked up by the kidney, and the bicarb is controlled by the kidney. So it's not as simple as being able to say it's only the kidney, but if you want to kind of just basically simplify it that way, your bicarb tends to be more of a kidney and a buffer issue, and your CO2 more of a lung and an acute problem. If something acute happens, it's gonna affect initially your CO2 from a lung standpoint, and then your kidney is gonna try and counteract that, and your buffer is gonna try and counteract that acid level, okay? So the bicarbonate gives us an idea of how bad the acid is in the bloodstream. If your bicarbonate is low, it tends to be because it's trying to counteract an acid. And again, usually coming from the lungs, but not necessarily. Premature infants, they don't really hold their bicarbonate really well. So initially they can spill bicarbonate in the urine, and that makes their bicarbonate be a little bit low. Most general numbers for a full-term kid are 24. But again, with premature babies, certain textbooks say you can even go down to 15 and it's actually normal, even though that in an older baby would be completely acidic. The next number we look at is your base excess. Your base excess is shown as a negative number if you're acidic or a positive number if you're alkalotic. So when you see a base excess or you just see on the gas a -3, it's telling you that the balance of neutrality, we talked about, being neutral, acidic or alkali, the balance is shifting towards the negative, meaning the acidic side. And if you have a +5, then you are more alkalotic. So this again gives you an indication of what's going on in the bloodstream. Are we on the acid side of things or are we on the basic side of things? And last but not least is basically the saturation. Most people don't look at that because there's so many effects. It can change a lot with the way you draw the blood. And so I typically don't look at the saturation of that. I know more in the PICU, in the intensive care unit for all the kids, they do tend to look at that number more so than what we use in the NICU. Okay, so that's a quick run through the actual gas. Please, if you have more questions on that, again, any of these topics, I'm more than happy to really concentrate and do a video on just that certain mode or the actual gas or talk about pHs. I'm here for you guys. So whatever you need, let me know. Please put it in the comment section. Again, if you like this video, please always, hit that thumbs up, hit that bell so you can, know as soon as I post something. I really appreciate the time. Again, this is the September NICU Awareness Month. I hope this helps some families, clinicians, anybody. Really appreciate the time, and we'll see you with the next video. Have a good one.